MedBix Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges on our live programming. Welcome to the MedBix Webcast. This is Ramana Annamaraju. I'm not Albert Einstein. Maybe my guest is. He is a very we have a very interesting guest. He is a MD PhD. He's a twice qualified. It's a double degree. So MD PhD. I love PhDs always. I'm a physics major. I have a master's in physics, and I did nuclear engineering. So always I love PhD people. And then he's a doctor, of course. He's not too far from here. I'm in Santa Clara. He's in Stanford. He did his dermatology studies in Stanford. After that, I'm going to present a topic on electricity and the physicians, what is the evolution of electricity through physicians? How do you measure the electrical system of the body through how they did from history to the present day modern technology? It's going to be good. But this doctor is Dr. Stephen Lewellis. I hope I said it right. Is a dermatologist, board certified dermatologist. As I told you that he's from Stanford in the MD PhD program. And then he finished it. And then also I wanted to ask him what kind of PhD thesis he did. But it's interesting is that he started a direct primary care. He's a very, if you see his profile, it's interesting. He says that very passionate and poetic. He says that he's going through, a lens, dermatology lens of the immune system as a canvas system. He's very techie stuff. Very interesting, no question about that. So he's a very passionate also. He's talking about the healthcare system in a dire situation. I met one of my friends. He's a longtime friend. They own several hospitals, and they're also telling me. The CEO is telling me we are in a deep, bad situation. It is a catastrophe in making. That's what he said. So without a further ado, let me bring Dr. Stephen Lewellis welcome to the MedBix Webcast, Dr. Lewellis.
Thank you very much for having me. It's a pleasure to be here.
Could you please give me some of your background and a little bit of your thesis background also? Very brief. We are not
You bet. No problem at all. I'm from Pennsylvania originally, but I did, as you mentioned, my dermatology residency at Stanford. Prior to that, I was at New York University, where I received both my medical degree and PhD. My PhD studies were just discovering how cells get in the very early embryo, how they get their signals to go where they need to go to form various organ systems. And that has applications to both fetal development, but also how cancers co-opt those mechanisms to metastasize, for instance.
So now where are you practicing? You just tell me, bring it up to the situation.
Sure. I'm practicing in central Wisconsin now. That is where my wife grew up, and we have 2 small kids now, and we live close to some of our family here, and we're very happy right here practicing in the heart of Wisconsin. And prior to that, I was in Minnesota, and so we've been all around the country, West Coast, East Coast, and now here, and I'm very happy here, and just started my own solo, as of now, direct care dermatology practice, and I'm excited to get that off the ground.
Except it's cold. I used to go to Waukesha, the GE
headquarters.
Oh, yes, sure. Waukesha. That's So, Dr. Lowellis, I see you're very passionate about what is going on in the healthcare system. So let us see that what is the big shift that happened? It is creating a lot of pressure to the physicians and the healthcare professionals. What do you think of that? What is causing that pressure?
I think it's a confluence of a number of events. The most obvious one that I see now that I am a physician who has experienced mainly life as an employed doctor and now just starting to experience life as an independent physician is the massive shift from physicians who ran their own practices and made the decisions and could sort of owned their own small businesses to massive consolidation on the part of large healthcare systems and insurance companies that feed those healthcare systems, and physicians becoming employees instead of business owners who were making decisions. We abdicated a lot of decisions to other people so that we could just take care of patients, and that's gotten us into a quite a big mess. And that collided with the dramatic pressures, financial pressures, decreasing reimbursements for physician practices, all these pressures that have made doctors seek employed positions where they have power in numbers rather than remain independent, because it has gotten so difficult to be independent with decreasing insurance company reimbursements.
I used to live in Georgia, Atlanta, and I used to place a lot of doctors in its rural areas, Alabama and Georgia.
Yeah.
Most at that time in 1990s, 80s, most of the physicians are independent physicians. They are
Yes.
independent practice. All
Yes.
of a sudden, there's a big shift came out because
Huge.
the HMOs came in, and then in Georgia, we actually a lot of physicians did not like it. That's a good idea, and then they really what our governor was a proponent of HMOs, but he was boosted out because of he lost election because he was promoting HMOs. All the
Hmm.
doctors got together and told the patients, hey, this is a very bad for healthcare system. So really that you have a powerful force, educating the patients. They did that in Georgia as an example. At that
Hmm.
time, they used to stay in my house because they just finished a residency. So I used to take them to the interviews and everything. So
Wow.
I had quite a bit of experience, and most of them are working for groups or independent doctors.
Hmm.
Now the entire shift is changed. So corporations came in,
Yeah.
the capital, the Wall Street came in. This is a big change.
Huge.
What is surprising thing is I wanted to ask you how that change, how do your government can do, what they can do to stop that kind of a take in India, for example. Even India is becoming, all the hospitals are owned by now corporate structures.
Mm.
So it is becoming a problem now. The patients are recognizing this problem is getting spreading across the world. So
Yeah.
how do we solve this at the policy level? Let us talk about the in the beginning at the policy level, then we can
Sure.
talk about individual levels a little bit later on.
That's unfortunate to hear that it is more than just the United States. It's becoming a global problem, and of course, with India having such a massively higher population than the U.S., that's quite troubling to hear. And I think part of what governments can do is have more oversight over the amount of how big these companies can get, how much consolidation can become, antitrust essentially, because that's what's happening. We're experiencing oligopolies, and that there's price pressures as a result of that, and limitation of consumer choice. So with the healthcare consumers, they have very little choice these days. They have their insurance and they're told where they are in network, and if they want to go out of network, they have to pay quite a bit in addition to already high premiums. And so that is that is hurting us, the lack of regulation in that regard. And on the other side, they can also support physicians much better. What physicians make in terms of what's called the conversion factor from the Center of Medicare and Medicaid Services is actually going to be lower in 2024 because of yet another cut than it was in 2001, and that's not adjusted for inflation. So we doctors make less money now, not in real dollar, in action, in just nominal dollars than they did in 2001 when being reimbursed by the government, not even adjusting for inflation. So that is it just doesn't even feel like a viable business model to a lot of physicians anymore. And that's why they join these groups. They get power in numbers, they get a little higher reimbursements from commercial interests. So the government really needs to pay attention to support doctors and at least tie that to inflation like it does every other part of the medical industrial complex, like hospitals and rehab facilities and things like that. It's only the physician part that hasn't gone up and kept pace with inflation. It just goes down.
What about the advocacy groups like medical associations? They're
Hmm.
supposed to represent you and
Yeah.
your associations. What their function and how they're doing it? It was a very
Yeah.
dissatisfaction among even physician groups among them. Just tell us a little bit about
There
what they can do, what they're not doing at this time.
there is quite a lot of dissatisfaction and cynicism among the people who are almost passive members of these groups. But there are things that some of these groups are starting to wake up to and starting to do, because there is becoming a critical mass of physicians speaking out against this because it's gotten so bad. So the American Medical Association, the AMA, for instance, that's taken a lot of flack over time for uh, perhaps not really supporting what's in the best interest of the physicians and sort of being in bed, quote unquote, with their per se with the big special interests. But they have wonderful resources for doctors who want to start independent practices. For instance, they have a great series that you can even access if you're not a member of the AMA, and I find that very generous. And they're trying to support people who are helping the pendulum swing back more to the middle, where there will be more balance. So there can be more of that, more focus on how these organizations can help individual physician practices and small groups, because the big ones don't need any help. They're already
Yeah.
powerful enough. So that's a big one.
I used to set up in Georgia and other places with a friend of mine, independent physician associations. We
Hmm.
used to go, and we are just the managers. We used to go there and negotiate contracts for the bunch of physicians together. That
Yes.
was a very good model, actually. Independent physician IPAs, we used to call IPAs, and
Yeah.
then it's an excellent model because we are negotiating contracts, the full risk contract or partial contracts. We used to negotiate for them, and then we get only a flat fee for us. So we get more we
Yeah.
get it for you. We get it. That kind of a model then died out after a while. Then HMOs came in and the different
Yeah.
products they spilled out. That is a big. So advocacy groups are missing, not
They
only
are.
associations, IPA groups, that IPAs, independent physician associations, that we used to manage. That kind of a system is gone, unfortunately. So let us talk about individual level. I used to set up practices for doctors. That I used to get SBA loans for them and get
Hmm.
them straight. It's much straightforward and easier. Now, individual doctor is so complex. I used to visit the doctor's offices. I tell you, Dr. Lewellis, very interesting. I hear whenever I used to visit the doctor's office, I used to hear the screams in the back office that with the insurance companies. Everywhere I go, it is just unbelievable. They were fighting nonstop. This is a ridiculous, unbelievable situation we got into. So individual doctors having you need a lot of resources to fight with these guys,
Yes.
big guys,
That is the
and then
problem.
you need an infrastructure, you need a administrative structure, legal, financial structures. All of them has to be there. And how do you think individual level you wanted to proceed in that direction?
So there are a couple things there. I want to revisit the point you mentioned right before about things like the physician associations, that we've lost sight of strategies like this, and we could perhaps revisit those strength in numbers that we could do as independent physicians. And I think that will come more and more as more independent physicians regain and reclaim their autonomy, because the big hospitals already do that. Big physician groups, consolidated groups, they go to the insurance companies and they negotiate. They have leverage. They negotiate better contracts. Then the little guys think we can't compete. So that's one thing that we need to take advantage of and start doing more of. And then also, you're so right that I think it's intimidating for a new doctor coming out, the amount of loans or debt that a lot of physicians have at the beginning before they even think of starting a practice, just from medical school and residency. And then they think about taking on another loan, and it's very intimidating, especially because of the overhead that you mentioned. It's not just having a few staff and yourself. It's the billers and the coders, and everybody wants a piece. And there's so much arguing back and forth just to get the small amounts that we're already limited to because of the financial pressures. So that intimidates people, and it cuts a lot of people out right at the beginning. So they just go join these big groups, just like I did at the beginning. I didn't feel ready for that. I thought that sounded crazy to me. So one way of getting around it is cutting the insurance companies out of the physician payment, my fee, not in terms of things, your medications your patients can get, things like that, but just reestablishing the transparency and the trust in the physician patient relationship. it hurts a doctor not to be able to say how much their services cost. That is morally injuring to a professional, in my opinion, and it's embarrassing. So if I am not contracted with an insurance company, I can decide how much I'm worth, and my patients can decide, or my customers can decide if that's worth it to them. And the proof is in the pudding. And that can serve many people. It's not just for wealthy people, because these prices are not extravagant. Because you keep your overhead low. If you do a model like I do, I don't pay billers, I don't pay coders, I don't have all these people taking a piece off the top, so I can keep my overhead low, keep my prices reasonable, but still be paid what I'm worth. And I can spend more, the amount of time with patients that they deserve, not just 2 minutes, 5 minutes, 8 minutes, 12 minutes if the patient is lucky, that kind of thing. It doesn't feel like a factory.
My father is a doctor in a small village. We used to, and then my grandfather is also a doctor. My father is a doctor and a teacher in the same small village, So my late father.
Mhm.
So, what we used to do is in a small village in India. So what we used to do is that once, twice a year, we do the special ceremony, and all
Mm.
the farmers come down and give us like chicken and eggs, that sort
Yeah.
of kind of
Yeah.
things. Then they used to give, and a concierge medicine. It was a practicing. It was a very effective, actually, concierge
Yeah.
medicine we are getting back. The question is, in the United States, the problem is that not everybody can afford now these prices. That is, it has to be extremely reasonable. But also there is some problem with this situation, Dr. Lowellis. I tell you what that is. A lot of patients thought that they were thinking this is a sick care system, not a
Yes.
preventive system. That is a big block to them, and they lost the confidence of doctor.
Oh yeah,
The devil's advocate. They lost the confidence on the doctors. They
I
are
agree.
representing pharmaceutical companies or
Mhm.
medical associations rather than representing them. That was a bigger challenge for the doctors to face now. Particularly, your generation of doctors needs to address that problem.
Yeah. That is a big part of what I'm trying to do. That trust has been broken, and whether or not it's our fault, it's our responsibility to try to restore it. And one of the things that has broken it is the misalignment of incentives. We are being paid by insurance companies if we are insurance dependent physicians, so we have to do, our incentives have to be aligned with what the insurance company incentivizes us to do in order to keep the lights on. And that if we care about counseling the people about things like nutrition and sleep quality and spirituality and quality of relationships and things that we know make every state of health better and every disease better, we don't that doesn't keep the lights on, because that's not a procedure and that's not a higher level of coding because you wrote a prescription or something like that. So it's the misalignment of incentives that burns us out on a moral level and ruins the trust with patients. So my way of solving that is through direct care and direct pay, which is not a new way. It's simply the old way of doing medicine.
Mhm.
And it's because I don't think that health insurance is insurance anymore. It's not. It doesn't work as an insurance product, which is why the premiums are so high, and there's copays are and co-insurance and deductibles are so high, because we use it for everything, and we shouldn't use insurance to get a mole on our shoulder checked. That doesn't make sense. That's not something you should use insurance for. But so, unfortunately, right now, if someone uses someone like me in direct care, they feel like they're paying twice, because they're paying for their insurance, but they're also paying me directly, and it doesn't go to their deductible. And so we're at a tough crossroads, but we have we have to do things to fight back. And the pendulum is swinging, but everyone has to do what feels right to them to rebuild that relationship.
And also, second thing is, first, I'm a physicist. I ask always question the first principles. First
Mhm.
of all, do you think is not the time for? Is it still? We think we need insurance companies. Actually, do you need them first of all to start with? Is there any? This the time has come. Their usage is gone. Actually, the time. What it is a the first principles of insurance itself, risk assessment, right? If
Yes, yes.
you if that is not there, if we can do in other optional systems there is, then
Yeah,
you don't need an insurance system. Suppose if some patients cannot afford to buy, the government can step in and pay that fee that you're asking. Same fee is a lot cheaper than there
yeah.
than insurance feeding the insurance companies. What do you think?
Yeah. It certainly isn't working the way it's done now. And but speaking to first principles, your point that the insurance product in healthcare does not function as an insurance product. Insurance is for things that cost quite a bit, for which costs need to be shared to prevent financial ruin or significant financial hardship, and these events need to be rare events. That's what insurance is for. That's why we don't use an auto insurance to change the oil on our car. Otherwise, the premiums would be through the roof and the mechanics would be not happy at all. So back to first principles is right, and perhaps there are other ways. I would love it if we just had catastrophic health insurance. That's what it's for. When someone needs
Absolutely.
a heart transplant, or they get in an auto accident and they're in the ICU for 60 days because they have traumatic brain injury and then rehab, and no average family is going to be able to pay that bill, and they shouldn't be expected to. So that should be shared across the group. And but because we also use insurance to pay inflated prices for the amoxicillin for an ear infection, and then that's why that ends up costing, the
Yes.
system $300 instead of the $6 that it should cost, because of all these layers and games that are played. That's the problem. So
Yeah.
I love insurance. I want insurance to stay. It's not insurance right now.
It's not insurance.
Yeah.
Uh, just extending that thought process. Why
Mhm.
don't you why we need a hospitals other than a catastrophic is acute
Yeah.
care.
Yeah.
Hospitals are meant for acute care. They can be
Yeah.
federally subsidized, right?
Yeah.
They can be
Mhm.
federally subsidized, and then all the private. For example, I used to own imaging center as a non-physician. I use an MRI center because
Mhm.
I want to give access to really people who are on the south side, and then I gave first time access to
Mhm.
mammograms and the MRIs. So my charge is $500, where the hospital is charging $5,000. It
Yeah.
is just ridiculous that way.
It
Why
is.
we need just to make the hospitals an acute care, just dedicate to the acute care, and all the
Yeah.
chronic care and other prevention move to the physicians itself.
Yeah. This is an issue of follow the money, unfortunately. I think because very smart people have gamed this system in ways that are really hard to unwind now. And because the way it was set up and the way you could we could add on this facility fee. So if we do it at a hospital, we can charge this inflated amount for it, even though it doesn't need to be done at a hospital. That's why now you get you can do a knee surgery or whatever, knee replacement, and some astronomical insurance bill is going to come at the end, $150,000, when the surgery can actually be done out of pocket at an outside independent surgical center for 30,000 all in. And that's what it's not. We're not saying it should cost $500 or the surgeon should do it for free. It can still make the business money, but the spread that these insurance companies, this consolidated ones, are taking home, that's, to me at least, that feels like that's where it's just too obvious. That's where all the money is, and they play the game. They're business people, so why wouldn't they play the game? So that's again where government comes in, and it's all entangled, unfortunately. But I agree, hospitals should be just for very big, serious things that require hospitals, just like health insurance should be for very serious things that require insurance.
No, yeah, but even though there's a big people, there is always one person's will change the world.
Mhm.
You have crazy enough. You're
Yeah,
Steve Jobs from Palo Alto. You're in
you're right.
Stanford. You know the game. So
Mhm.
even I live in Santa Clara. Even here, there is two different islands. Technology is on one island, and the medicine is another island.
Yeah.
I struggle to very few understand both fields, where even if I try to come up with a problem, nobody paid attention to me. I solved the problem of this pandemic kind of things, but this is a big problem. We need to, technology is excessive technology is not a useful.
Mhm.
You need to use a moderate technology
Yeah.
that makes sense,
Yep.
and then that in anything other than that is just a excessive cost.
Mhm.
Artificial intelligence, and tell us a little bit what is your perspective on the technology side of it.
I think we need to be so much better in that regard. And it's just like everything we talk about, it's about balance. The pendulum for doctors has been a long time. Just the joke, we still use fax machines, et cetera. Yes, that's important for certain reasons, but the the pendulum is so far on the side of slow to adopt because it's medicine. We can't move quickly, and it has harmed us because of there's such potential in technology. So we just need to swing it back to the middle, not back to the other side where we have this unending tech debt and these just gargantuan things. The electronic medical record, for instance, that is one thing where it's it's massively used and massively expensive, but that's because things like Epic, medical records like that are glorified cash registers. They capture what the insurance companies require in order for hospital systems to collect the largest amount of the premiums possible. That's what they're for. That's why no doctors like them, because they don't actually help very much for healthcare. So my perspective on medicine, on technology, is early adoption. Use it for things that enhance patient care, that make the patient experience feel like it's the 21st century. And I want my patients to feel like, wow, that was a different experience. I wasn't expecting that. That felt like, the experience I expect when I go on Amazon or something like that. It felt modern, but it didn't feel bogged down with technology. It still felt human. No worries. It still felt human, and I can see that this doctor cares about using technology to enhance my experience and give me more value for the money that I'm paying. And
You
and there's
know,
things like, go ahead, sorry.
you mentioned Epic, Wisconsin. I tell you something about
Yeah.
that. I went to school. Epic actually it came from a BA hospital system. Epic
Hmm.
language is MUMS. My friend used to work on that. Only 5 people know that language. They took it's a federally funded programming. It's free. It's an open source.
Yeah.
They took it around, and then they are charging back to the. Then they don't want
To
to
the
give the
government.
data back to the public. It is
Yeah.
a very, that allows that kind of a, that's a self-stabbing of this healthcare
Yes,
system is
it is.
unbelievable.
Hmm.
That. So I think we have to. The my Yesterday I met a friend. He was saying that healthcare system should, and Dr. Todd Orton
Hmm.
also was talking about it.
Yeah.
Like Lord Shiva, we need to destroy the healthcare system completely from the ground
Mm.
and then build up from the scratch. I don't
Yeah.
know.
Yeah.
It is a really sad story, Dr. Lewellis.
It is.
My heart goes out to the. If I am on the both sides of the coin. I tell you that I'm not a doctor, but I
Mhm.
understood both sides. I tell you that if I would have gone to the other side, I would have been a billionaire. I'm
Sure.
struggling because I'm advocating physicians, because my
Yeah.
grandfather, these are the people practicing in small villages. I understand the
Yes.
passion, and I used to do ultrasound for small people in Georgia, rural Georgia. They didn't
Mhm.
get ultrasound. Even woman that she didn't know even she has twins until the seventh month or eighth month.
Wow. Yeah.
It was a terrible. So we have to change the system. People like
Yeah.
you raise the voices, and then
Mhm.
and also one more thing I would say. This one, if you see a movement that you're trying to initiate, that movement,
Yeah.
if you take an example of Martin Luther King, for example, he took the not just by civil rights movement, he didn't win by just doing black people. He had a lot of
Yeah.
whites, other cultures supported him at
Mhm.
the time. So for you, not only there are people who support your system, including non-physicians, you need
Mhm.
to take their help. It's administrative, legal,
I
uh,
agree.
or management structure. All of them you need.
Mhm.
Financial structures, all the resources you take together, because doctors alone cannot solve this problem.
I
You
agree.
need other people who believe in your idea, believe in
Mhm.
your passion. That's what you need. What do let
I
me
I could not agree more, and I want to end with optimism. I am hopeful. I used to lament coming up as a physician in this day and age, but now I have become optimistic and hopeful about it because it's a time it's a palpable time of change. And anytime there's turmoil and this amount of talk about change, there's a lot of opportunity to change the system, 20 years ago or 10 years ago, maybe people were feeling it, but they didn't feel that there was momentum towards change. So they felt much more helpless. I don't feel helpless right now. And I look at people like Todd Otten and his medicine forward and things like that. There's momentum. There are these waves swelling in the distance, and there's optimism, and there's this inertia that is being overcome. And once you get the ball rolling and that snowball rolling, that is huge. And we do need those other people, and they're out there. I'm meeting them on LinkedIn. I'm meeting them through my podcast. And each one of us makes that ripple again, like Todd says. It's going to inevitably make a huge change, and it might not we might not have to tear the whole thing down, but our voices will be heard, and we need to learn from other people and invite help in, because we can't do it alone, and we don't know how either. We're not good organizers. We're good at taking care of people, and we need to enlist the help of the experts who really know
Yeah.
other things.
You know, when humanity is in crisis, we always need to take a wisdom of sages. That's why I'm
Mhm.
going to present the people who contributed to the science and medicine. I'm going to
Sure.
present a topic for you: is the electricity, how they struggle through the physicians, how they struggle through the whole process of electricity bringing to the human body and the inventions. You may know already, but I'm going to present both of us. You can jump in anytime. You can. I
Beautiful.
love your comments in the sense. After that, I come back and I will ask you what are the practical steps you can take it, and then what you're going to do, all the associations. How do you form this kind of a IPA kind of a structure you can form and then do as a movement, and then a passion you create. I think it is a time where you should be
It is.
optimistic, and let
I agree.
us go with the optimism. Learn from these sages, wisdom from sages. I'm going to present a topic. Both we watch together in a minute. Let me just let me this okay, just give me 1 second.
Mhm.
Okay, so this is the electricity. I'm going to talk about the sages of the physicians, so I'm going to present a topic on this. In 1964 there is two doctors. Dr. Yeah, let me 1 second. Let me bring this. Sometimes my glasses are not that good to see. Okay. In 1964, the two neurologists, Dr. Luder Decky and then Dr. Hans Helmut Kornhuber, the two German neurologists, they met in a Black Hills in the Germany at the restaurant called Gustav Zum Swanchen. I don't know. I hope you know the German than me. So it's
Mhm.
Gustav Zum Schwanen is a restaurant. They met at the restaurant, and they sealed the fate of law of karma, the predeterminism versus free will, by reading the signals from the electrical signals from the brain. That's what they called it is a Bereitschaft potential. Is a lot of German twisting words. It's a basically readiness potential. That's what they did. What is a predeterminism? The predeterminism is predicting decisions before conscious awareness. You're executor of the action, not a designer of the action. In a Hindu philosophy, law of karma is like you're basically you're executing, you're not making the decision, you react like a is a
Mm.
illusion that you're making your own decisions. So that is a electrical signals. They decided that fate. Actually, that livid experiment came after that, and the proved a functional MRI is proving that something if we do, the body also the is making a decisions before even consciously aware of it. That's a very interesting concept. It is a functional MRI is validating some of those experiments. That's very, very interesting. So we need to talk about the body electricity in the body, and how do you measure it, what are the things, how they did from the beginning of this, how the physicians played with electricity. That's one thing I wanted to talk about that. So everybody know this is the happened in the late 17th and the 18th century, in the Enlightenment period in the Europe. There is Johannes Kepler, and then Rene Descartes. All this is very Baruch Spinoza and Immanuel Kant and Isaac Newton. All of them are important. And Emily de Châtelet. These are all during the period of the Enlightenment period in the Europe. They were, during that time, they found out first one, his name is, this guy's name is a doctor, is a Giovanni Aldini, is a physician, is a from Italian physician. He is born in a Bologna, educational center in Italy, and then he spoke several languages, French, English, Spanish, and Portuguese. He spoke several languages, Dutch, So at that time, galvanism, resurrecting the life is a big thing at the time. That's the beginning of the 17th, the late century, 1700s and 1800s. So what he did was, this is his uncle is a Galvani, Luigi Galvani is a one who is experimenting the electricity with the frogs. He was connecting the wires between the head of the and the legs of and the twitching. When you connect the wires, copper wire or any wire, that metal wire, it is twitching. They thought, Luigi Galvani, his uncle, thought there is a life inside. You can resurrect the life, So it's already Vatican City is not that far from there. So that's. But Aldini was a physician. He did not believe 100%, but he did a lot of experiments on the animals. He extended all his experiments with all the animals, several animals, and he wrote a first runaway book, a very big hit, big seller. It's called Animali Electricitati. It's called Animali Electricitati. It's one of the best-selling books during the time, in 1700, 1800. So after that, this doctor wants to extend his experiments to the human body. But Vatican has a strict principle. You cannot test dead bodies. In Vatican, the center of the Christianity, they don't allow any dead bodies to play around with. So what they did was he moved to because he speaks English and all those languages are fluent, he moved to England. In England, there is an exception. If somebody gets hanged or executed by the death penalty, that body can be experimented. So he moved to London. Dr. Giovanni Aldini moved to London and he put a shop up there. And then there was a guy that he killed a drunken state, killed his wife, George Foster, his name. What he did was on December 4th, 1802, he drowned his wife and a child in the Paddington Canal. So immediately, without a very quick trial, went on, and then they sentenced him to death by hanging. Immediately he was actually one of the guys working as the lobbyist. He has a lobbyist too. Giovanni Aldini has a lobbyist. A lobbyist is very close to the Queen Victoria, I think. So she immediately got the body transferred to Newgate, where the surgical center is. Then after that, then he called all the royal surgeons. It's a spectacle. He invited all the people and all the physicians to show how the electricity works with the human body, dead body. So then he took another Italian who already made the first battery, Alessandro Volta, his name. That's why we call voltage, volts, 9 volts, 5 volts, because of his name, Alessandro Volta. He is the inventor of the first battery. The battery, how he did was he put the zinc plates and put the salt water in between, and then he connected the through wire. Then he produced the chemistry produces the electricity, and then he connected this human body, his dead body of George Foster. So what happened was that this is a gruesome experiment. It is like the body contorted, shaken, stood up, and then London Times published a paper that's saying that there is a demon behind behind these things. That is actually the middle one is published in the London Times. So it is when the electricity took it, they thought something life force is created within the body. But nothing happened. Actually that is the one during the time, just a few years after that, Mary Shelley father was talking about the galvanism, electricity experimenting with the human bodies and the animals. So she heard the stories of the Mary Shelley. She wrote the inspiring story. She wrote the horror story of the century is a Frankenstein. She released the first 500 copies January 1st, 1818. as a runaway, she put the entire generation of children into the fear. So that's the concept of came from the galvanism. The physician who is playing with the electricity with the human bodies. That is the inspiration for her book. So actually, electricity and magnetism are both are same manifestation of the same force. Electricity and magnetism. I'm a physicist, and I learned these kind of things. Michael Faraday discovered the electricity. So if you run the electricity through a wire, it produces a perpendicular, right thumb rule. It produces the magnetism, and other way around, you can reverse it. You can take a magnet and put it back and forth, and then it will produce the electricity. Electricity and magnetism, electromagnetic force, is the same manifestation of the same force. So James Maxwell, another English physicist, gave a excellent mathematical structure, Maxwell equations. They're so even today, those equations are for a physicist like us. It is like a golden. It is a gold. It is like they run the whole entire universe through the electromagnetic wave equations. That is one of the most brilliant geniuses who gave that equation mathematical structure for the electromagnetic force. Then electricity and magnetism. Nikola Tesla, everybody knows Tesla cars in Stanford. He's actually invented the X-rays. People didn't know that. Is a shadow graphs. He used to call shadow graphs. That he dithermy, then the electricity, and produces the physical therapy. He uses it and produces heat, right? So he used that one. So then came in. Then, then as you all know, you're a doctor, so you all know heart and muscles and the brain. There's electricity. These are body's electrical system. We can measure them through different equipment, right? So you measure So is actually first EKG was invented in 1920, before 1920, actually 1900s. In the beginning of 1900s, EKG is 600 pounds. 10 people used to carry that EKG machine, ECG electrocardiogram, to measure the heart signals. So then he won the Nobel Prize in 1924 for that. Actually, think about what they did, how much they did all these years. So now heart is measured by ECG electrocardiogram, and the EEG electroencephalograph measures the brain electrical signals from the brain, and the EMG nervous electrical system electromyography. You can measure all those things. We have but my question: wherever there is electricity, there is a magnetism. How come we don't measure the magnetism? The reason is the heart produces magnetism. The heart is electrical system. It produces a magnetic field, and the brain is also produces a magnetic field. How come we don't measure it? That is a question. How do you measure the magnetic strength? Because Earth's magnetic field is 25 to that is Earth's magnetic field is so just a minute. Let me bring that to that it's 25 to 60. I think that is electric magnetic field is I'm just let me go back. Magnetic field is very weak when compared to the human body is a billionth of a Tesla, micro Tesla. We have 25 to 60 microtesla is a billionth of the portion of the magnetism. But magnetism produces, if you get the images from the magnetism, it produces the spatial and temporal resolution is way higher. It's way higher. So that's why we need that is where I'm going to show you a quick video on the video that this video is actually Wisconsin is involved. You can listen. I hope this is the one. Yeah, let me show you the video. I'm going to play.
You might have heard about a psychic squid that predicts a World Cup winner, or at least you have seen at the dinner table. The squid I am talking about is neither. This squid accidentally fell on us 100 years ahead of its time. The squid contribution to the medical field is invaluable. It revolutionizes the way you predict and diagnose diseases. This squid hunts cancer cells like you've never seen before. It will pick up source of seizures in the brain like no other. It is just not picking the needle from a haystack, it can pick your lost nail from the Appalachian Mountains. Hello, my name is Ramana Anamaraju. I have a passion for physics, specializing in allied healthcare, and above all, concern for well-being of all humanity. Edward Flynn was hit by tragedy twice and lost both of his wives to breast cancer. When his first wife fell in coma, he used to visit her at the hospital. He used to whisper in her ears, wondering she may be understanding what he was saying. After a few months, she died. Not knowing his wife understood his undying love for her or not is frustrating. Then second wife, after a brief marriage, lost to breast cancer again. He is determined to do something about it. Edward Flynn is neither king nor can afford to build a Taj Mahal in memory of his beloved wives. But he built something better. He built SQUID. Acronym for SQUID is Superconducting Quantum Interference Device. As strange as that name is, this device is out of this world. He brought a mystical and elusive quantum nature of our universe to the benefit of the world of humanity. Edward Flynn is a nuclear physicist at the prestigious Los Alamos Defense Laboratories. He gave a remarkable gift from mother of all sciences, physics, to the field of medicine. A new machine, magnetoencephalograph, was born, usually referred as a MEG scanner. This exotic hair blower looking machine is a mag helmet made up of several squids, which are quantum devices that are designed by Edward Flynn's team. This machine, without touching the body, can read magnetic fields coming from a body that are 100 million times weaker than our Earth's magnetic field. Amanda Malmsberg of Wisconsin fell on the kitchen at the age of 8 with the first epileptic seizure. She was getting seizures almost 100 times a day by the age 16. With the help of neuroradiologist Dr. Deepak Raghavan, they made a journey deep into her brain by using MEG scanner.
MEG, or magnetoencephalography, is a relatively new tool that's become available to us, which is capable of looking at the magnetic fields generated by the brain and localizing them back on the anatomy of the brain. At this time, Fredericton Medical College of Wisconsin is the only center in Wisconsin which has a clinical MEG program. We do see patients from not only our hospital but other centers as well. Most people are familiar with electroencephalography, or what we call EEG, where you record brain activity or brain waves from electrodes that are planted on the scalp. Now, there is a substantial amount of tissue and fluid that separates the generators of that electrical activity in the brain and the locations at which we are recording this electrical activity, including tissue such as the skull and scalp. So that can substantially alter the view of what we are looking at in the brain, pretty much in the same way that if you're trying to listen to a conversation through a thick wall, you hear muffled sounds. You may vaguely be able to place people in different parts of the room, but not quite clearly see who spoke from where. So alternative techniques which are not affected by the tissue is of great interest.
Without single incision looking for the elusive source of epilepsy, it is just like looking for a needle in the Grand Canyon. It is that difficult. They found the source of her problem hiding deep inside of her brain. No other modality, including powerful MRI, even come close to these findings. The very tiny source of area that is causing her seizures was surgically removed, and Amanda is living happily ever after without even a single incident of seizure. The woman's life was given back by this remarkable machine. The researchers racing towards to find that very tiny number of cells that causing Alzheimer's, schizophrenia, depression, autism, and chronic alcoholism, and many other brain-related diseases. MEG scanner is taking on the most challenging and the deadliest disease of all for women, breast cancer. With the present technologies, you need 10 million cells to be affected before it shows up on any modality or device like a mammography or MRI. But the MEG scanner hunts for those few thousand cells causing cancer out of 90 trillion cells, not a billion, 90 trillion cells. Probably MEG scanner can detect breast cancer 5 to 10 years in advance before any modality. Vanderbilt Gastrointestinal Squid Technology GIST Laboratory is an interdisciplinary initiative by the Department of Surgery and by the Department of Physics to detect how to find stomach ailments. Can go on. This is a direct demonstration of quantum physics in action through a medical device while saving countless lives. Nuclear physicist Edward Flynn may not have saved his wife's life, but saved countless lives on her memory and will be saving millions in the future. It is better than a Taj Mahal indeed. Thank you for listening.
So, the Dr. Lewellis, that's from your home. Actually, Amanda Mansberg, she lives in Wisconsin. She's a primary care teacher now. I saw recently an article about her. She's grown now. She has her own kids. It's a very interesting concept, So let me then actually, if you want to see that, now this transcranial magnetic stimulation you can use a therapeutic purposes, repeated pulses. You can use it. So Magnus is one of them from Stanford. Magnus Medical. It is actually they use a repeated transcranial magnetic stimulation to the particularly drug-resistant depression, the resistant depression, and also very the multimodality. It's a very getting popular now with the transcranial magnetic stimulation. But there is this one is out of this world. It's called microfabricated atomic magnetometer. They invented this. It's called a Zeeman effect. It's a physics. They call it Zeeman effect. It is a very strange effect. It's a very fascinating effect. We use when an electron jumps from the one orbit to the other orbit, it emits sometimes it absorbs or emits sometimes a photon. Sometimes what happens is when you put in the magnetic field, when it jumps, it is also it's a quantum phenomena. It splits into three lines, spectral lines. So you can use that Zeeman effect. So they can get this small quarter-looking magnetometer. You can wear it like EKG nowadays. People are wearing like EKG machine. You can put the magnetometer on the heart. You can detect because of this. It is no cryogenics is involved, no attenuation problem, everything because Zeeman effect is room temperature. You don't need to even cool it down. It's an amazing invention. Texas Instrument is working on it now. So it is a really phenomenal things are happening in this world. So magnetoencephalograph is magnetocardiography is coming up. It is actually particularly for the congenital heart defects and CHD complex things. Dr. Lewellis may know better than me in that sense. So these are all things coming up. With the magnetometers technology, as some there is a role for it, and then if you use it, so electromagnetic field, that's the electromagnetic force can save millions of lives and children's lives. Everything. It is a phenomenon that we are. That Newton said that we got all these things on the shoulders of the giants. If you see Aldini and Kepler, and then this Nikola Tesla, Jagdish Chandra Bose, we gave a physics of the semiconductors, and Benjamin Franklin, who did the electricity experiments. We're standing on the shoulders. So we learn from the sages that actually how do we inspire and what it takes, that passion that they came up with it. Let me bring Dr. Lowellis back to the stage, so we can talk about it, just what do you think, Dr. Lowellis?
I'm just grateful to have been here for that presentation. That was a wonderful presentation. You can feel in you your passion for teaching and just understanding the world and the mysteries of it, and the people who have worked so hard to figure those things out incrementally over time. the history of medicine is so important and critical for us to remember, and also to remember to keep that we need to keep pushing it forward too, because medicine can seem like a somewhat of a stagnant field in some ways, even though we're having new drugs come out all the time, things like that. So I'm just inspired by your sense for that, and that, you've gone out of your way to teach us all about that. I understood the concept of electromagnetism and how intertwined they are, but knowing about the Meg scanner and these oncoming technologies, we're just so lucky to have. And my brother had treatment resistant depression. He passed away, unfortunately, but he was undergoing TMS and was actually getting better from that. And it's just, we're making these these sometimes incremental, but sometimes uh, boundary breaking breakthroughs that are so important. And I think we can apply that to how we can move forward in the difficult position we're in. You brought up Martin Luther King before. The battle we're in right now is not like, not the severity of course, like the civil rights battle, but it doesn't matter in comparison in those terms. The principles are the same. The first
It is the
principle
worst, Dr. Lewellis. I tell you
is,
why. Because
oh,
the
fair enough.
entire population is suffering now.
You're right.
Not just
Fair
at
enough.
the
Fair
time
enough.
one segment of population now. Entire, all the people. If I go to Georgia, Alabama,
Yeah,
Tennessee,
you're
the
right.
humongous rural areas, urban areas, they're all
Mhm.
suffering.
And we still have the legacy of while we've made so much progress in civil rights, we still have the legacy of how much progress we still need to make, because when you look at the data, marginalized populations are still suffering more disproportionately from the ills
Well,
of our healthcare system as well. So that really is, we need to remember that we can each make an impact, and by casting our vote for the future, for the future
yeah,
that we
absolutely.
want to bring
No,
about. And I'm just
what is
trying to do
happening
that.
in healthcare is worse than civil rights, in my view. It is a
Fair enough.
real injustice. That's even Martin Luther King said that among the injustices of all, the worst injustice is health. Disparities of health and all those things.
Mhm.
We have so what you are coming with a passion. So let us talk about a little bit practical. You're doing a podcast. What is a podcast? And tell us a little bit about your podcast, that
Sure.
Lowellis.
Yeah, my podcast launched at the beginning of January of this year. It's called the Direct Care Derm, and what that means to me is I want to bring, as a dermatologist who is using this concept of direct care, which again is just going back to the old model of medicine, directly from the physician to the patient, patient to physician, without everyone else standing in between, and helping teach other physicians, regardless of their specialty, that they can see that as a feasible way for them to reclaim the practice of medicine, and enjoy practicing medicine again, and a way to really help people who need it and get it to lots of different people. So the podcast is part blueprint, part inspiration. So we bring on people to tell us about their stories and learn from those stories, but also understand some logistics behind it as well, how we actually succeed in this way. And direct care is only one way of solving the problem. It's not the only way by any means. It's my way that I'm doing right now, but I believe in more than just the time I spend with a one-on-one with a patient. I want to leverage my voice, my expertise, my responsibility as a physician far beyond those one-on-one privileged times in the exam room.
What is your
And
website? What is your website, Dr.
the
Lewellis?
the website for the podcast can be found on my personal website, lewellismd.com, my last name, then md.com. And the one that you see that on the bottom, it's retinoids.lewellismd.com. That's just where you can get a free gift. Sign up for my email newsletter that comes out once a week, and you get a free gift about where you can learn about using what are called topical retinoids, retinol or retinoids on your face every day as part of a daily skincare routine. That's great for acne, great for anti-aging. It's very low-hanging fruit, but not enough people know about it, because not enough people get to see a dermatologist, because there aren't enough of us around. So just a little free gift from me, and you can get on my email newsletter, which is another way I try to leverage my voice as a physician. And I talk about business, I talk about life, I talk about how I'm building my practice, I talk about the things I care about in terms of treating patients holistically and integratively with both Western medicine and all the wonderful drugs we have for skin diseases. It's a wonderful time to be a dermatologist, but also caring for people from a sort of mind-body connection level that you are clearly passionate about and aware of, because all those things matter so much to relieving our disease and bringing wellness.
I was talking with the Dr. Robert Perla. I was asking him online, where are those leaders? I see right in front of me, you're one of those passionate leaders you deserve. I think you will be head. You will be head of leading those kind of things.
Thank
And
you.
with your passion, I'm deeply honored and privileged to talk with you, Dr. Lewellis. Thank you so much
Likewise.
for joining our podcast.
You're very welcome, and I feel the same about you. It's been a pleasure to be here. Thank you for sharing your platform and for your enthusiasm and for teaching all of us and being an advocate, a non-physician advocate. We need as many of you as possible, and you're very selfless in doing that, and you really do care. So thank you.
Thank you all. Good night. And, good night. Thank you so much.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it.